Okay. Just a minute. Perfect. So I think you can see that screen. That's my PDF screen. So I was just looking at those three areas that we've talked about, from coordination between the national, county governments in terms of the COVID response, our supply chain mechanisms and manufacturing that is now addressing the pharmaceutical, the non-pharmaceuticals. And we've seen with this COVID-19, there's been a demand for personal protective equipment that ranges from the coveralls that healthcare workers would use, the gloves, the masks, and everything that we've seen that has been in need by the healthcare workers. And then the other part is on the containment measures that we've seen, and this speaks directly to the consequences on the public healthcare in the country. So I'll start with the supply chain. So coincidentally, the epicenter of the COVID-19, that is Wuhan in Hubei province in China, happens to be sort of like the pharmaceutical hub, where there are 42 companies, there are contract manufacturers who do produce the active pharmaceutical ingredient that is used in the manufacturing of the end product, which is the medicines that we use. And we rely a lot in this country, like 70% of our imported generics are from China, are from India. India, on the other hand, gets this active pharmaceutical ingredient from China. So when there was a lockdown in Wuhan, when there were restrictions in Wuhan, then it meant India felt the impact of this. And when now the lockdowns also started in India, and when these things were happening, India sort of ring-fenced or locked down whatever they had for their own population, because they were unsure of what effect it would have in supplying the medicines normally to other countries, when in their own population they would not be sure about continued supply to their people moving forward. So there was that. And though we did not feel a direct impact, and we are not feeling it yet, in another 6 months, 3 to 6 months, let's say from June, we may start feeling those direct consequences of what happened in February, March. Now, what usually happens from India, then you get an importer or a main distributor who then brings the medicines to Kenya. And from here, they get a sub-distributor or a wholesaler who then distributes to the retailers, who then finally supplies that to mwananchi or whoever is buying, like you and I with a prescription, going to get. So what has happened, or what has worked to our advantage now, is that because of the lax regulation on medicines in the country, for one molecule, you'll find that there are at least 100 other brands of the same. So if you're looking for paracetamol brand A and you're used to paracetamol brand A, you may not get it, but there'll be 99 or so other options for you to choose from. So at the moment, we do not anticipate that all these brands will run out at the same time. We will have something, and around between June to August, September is when we probably may start feeling this impact. So what should happen here is for us to wake up and realize that we can actually do our own manufacturing. Now, the local manufacturers have capacity to do that, but there is low demand for locally manufactured medicines. You find that the bulk of our locally manufactured medicines are in the public sector, while the private sector rely on the innovator brands from the big pharmaceutical companies or these imported generics. So we need to probably shift and relook at our sources of medicines and how we consume medicines, and probably start consuming locally manufactured medicines. For example, you may find that a whole dose of a month's medication of antihypertensives, for example, medicines against high blood pressure, would probably cost you 500 shillings if you are to buy from the locally manufactured people. But if you are to rely on the big pharmas or the imported medicines, with all the changes in shipping because of freight, because of shipping and cargo flights having altered or suffered some hit, where you find the Kenya shilling is suffering against the dollar, then you may find that prices go up, and it may be anything to even 40 times the price, which is like even 20,000 per month. So if we compare what we can do locally versus relying on importation, then we find that this is an opportunity as a country for us to relook at where we get our pharmaceutical supplies and whether we can boost the local manufacturing from where they are at 50% capacity to supplying 80–90% of the market, so that only a few of the products which they cannot be manufactured locally then can be imported, because then it will be absolutely necessary. Then the other thing is probably to relook at how we regulate our products. If you have 100 brands of each product, and the Kenya Essential Medicines list has, I think, 10,000 molecules or so, then you can see the number of companies that the PPB needs to be looking into to see their authenticity and their quality of manufacturing. So it becomes a catch-22 situation where right now, yes, it is working for us, but in future, we want to continue with that. So I think COVID-19, in terms of looking at our supply chains, manufacturing, is a lesson for us to rethink how we do this and probably start supporting locally. Now, on county versus national government, this is just a screen grab from the situation report that the national government emergency operations center, or the committee, the task force, has been producing on a daily basis after they have done the analysis of what has happened. So I just picked two of these, and looking at not just these two, but all others that have been there during this particular time, there's been one running commentary that there's been lack of coordination between county and national government, or it has been suboptimal. And then you see there that the issue of contact tracing at county level has not been adequate, and it's been a running commentary. There's also been an issue with reporting to the Emergency Operations Center from the counties. There's just been a lack of seamless coordination between county and national government. And then on that, you find that other counties, and I'll give Mombasa here as an example, seem to have gotten it right, where they have prepared their hospitals to be able to handle anyone that's suspected to have COVID. They have a COVID center now at the Technical University of Mombasa. They were looking at how to provide food for people who are vulnerable and who may not otherwise be able to access food during curfews and lockdowns. Found that the leadership of Mombasa County was vocal when the start of the curfew began, and the police were clobbering and beating people when they were going to access the ferry, and even this was happening in the rest of the country. So you find that county seems to be their own little center of power. The national government has their own little center of power. So there are so many centers of power, and the direct effect here is that what is being discussed at the very top is not percolating to everyone at the bottom, so that everyone is on the same page, so that somebody knows that if A, B, C, D happens, then this is the reporting mechanism. We saw an example now on the extreme end in Siaya County, where Mr. Oyugi was buried in a very inhumane manner. And you wonder why, because the national government had prepared protocols, very nice protocols about how to, quote unquote, dispose of remains of anybody who has died of COVID. But then you find that at the county level, something totally different was done. So you wonder if there was good communication and if there was something seamless, would our COVID response have been any better? And two, is it too late for the counties and the national government to reorganize and reorganize themselves to redo and do better in terms of the COVID-19 response, so that there is a seamless flow of information, of coordination, and response to alerts on suspected COVID. Now, my apologies, that other picture disappeared when I was exporting this, but this one I was just looking at the consequences to patients. So the picture that is here that is not showing was people who are not able to access healthcare services because of the curfews. You remember when the curfew was put in place, then people are unable to move at night, even when they have an emergency, which is a very big problem, particularly to mothers. On the left here, you're seeing that these mothers have had to go back to traditional birth attendants. They've had to find ways of still surviving, because yes, we have COVID, but the other healthcare services are still necessary. People will still have to go for the immunizations. People will still have to deliver, which is most of the time an urgent issue, if not an emergency in some cases. People will still get strokes because we have people living with diabetes, hypertension. Then the other thing was that surgeries and clinics had been stopped temporarily by the Ministry of Health, because now everything was towards COVID response. And the question was could it have been done any differently? Because would you better kit your healthcare workforce so that they are better prepared to receive anyone who comes to the hospital, so that you are able to manage everyone else? Because if you take something like cancer, if somebody needs any surgery to manage their cancer, and now theater and operations are being stopped, what happens to this particular person? What happens to their well-being? Are they able to catch up? Because this cancer will still grow. So here we've seen that the measures that we've put in place, for every action, there's been a reaction, and for every measure, there's been somebody on the other end of the divide who's been suffering and who is not able to enjoy the benefits of continued or sustained healthcare service provision. And the sad thing is that counties seem to also be struggling, not really putting in place, let's say, a workflow mechanism for people to go to continue seeking healthcare services. Only a few hospitals have managed to do that. But this, I think, should have been something that should have been thought of holistically, so that we don't get to hear mothers that we've lost because they are unable to go and seek delivery services, and we've lost mothers. And the unfortunate thing here is because people have to be buried so quickly, we may not get a real audit of the consequences that we have suffered from COVID, because people are getting buried so quickly. Some are not even getting registered, or a postmortem is being done so that we know the cause of death. So at the end of this, we probably need to do a thorough audit so that we know the real human cause of the COVID-19. And now to my second last slide, this is now the healthcare workers. This is the most recent one on Monday at Blue Post, where it's almost like every other Monday. I think it's because when the security personnel are changed, then healthcare workers are unable to access their workplaces. Because remember, healthcare workers, some live in Nairobi and still work out of Nairobi. And because of this, then it would have been difficult for people to reorganize their entire lives to go and live elsewhere, so in order to keep the curfew. Remember, these are also parents who still have to do homeschooling for their own children. So there's a magnitude of issues around. So this has been the consequences. So you can imagine, if healthcare workers are stranded, what about patients who need to cross to the other side, let's say come to Nairobi for healthcare services? What happens to the people on the other end who are waiting on these nurses and doctors to attend to them? So these measures probably needed a little bit more rethinking and having a way of looking at them holistically. So yes, we need to rethink our containment measures and move it from a security operation to a public health intervention, because that is the only way where we get a sustained behavior change. Because what we are seeing now with the COVID-19, you need you and I more to understand what's happening so that we can implement it through and through. Contingency measures and plans for other healthcare services should have been rethought of. It may not be too late to reconsider that, so that a clear plan of how other healthcare services will still be provided is accessible to every Mwananchi who needs to seek those healthcare services. Then the Ministry of Health needs to be clear on its strategy to citizens. I think of late we've been wondering, okay, what is the plan? What is the end game, or what is the roadmap of the Ministry of Health in being able to contain the coronavirus, or even de-escalating some of these measures, or escalating if necessary? And this is something that hasn't been very clear. Then the last one is to get a little bit more transparency. And I think my colleagues who would be addressing the issues of financing will be very clear on this, because now, as we saw yesterday, there are a lot of gray areas that still need to be addressed. So that is my long and short. Thank you so much for your attention.
Okay, thank you so much, Dr. Masi, for that very wonderful and insightful presentation. And what will happen, I know probably guys have questions. What we will do is kindly write down your questions. Then we will have a plenary session where you'll be allowed to ask the questions you have. So for Dr. Masi's presentation, three things stand out for me. The big question is what counties like Mombasa are doing that other counties can learn from. In as much as there has been a lot of noise on, oh, this is happening in Mombasa, and it should not be an unnecessary noise, but rather a noise that informs and helps other counties to then realize that there's something right that is being done in Mombasa that can then help the whole country to address this pandemic that is here with us. And then, of course, we have had issues of other healthcare services being on a slow. When a pandemic strikes, that does not mean that other healthcare services come to a halt, because all the attention is given to the pandemic at hand. We should have a mechanism whereby all these other issues are still handled and sorted out without ignoring the fact that the pandemic is here, because either way the pandemic has to be handled. But as we handle it, we have to be careful not to allow these other health issues to be ignored. For instance, the example Masi is giving for the women who need to deliver, surgeries need to go on. We can't put those on hold because we are dealing with the pandemic. And on the issue of what the plan the government has for us, because we've been in a session, this is the 4th week for Mombasa, Nairobi, Kilifi, and Kwale. And you realize that even with that session, we are not being told what exactly is going on and why we are being kept home. Is there a mass testing that is planned for Mombasa, Kwale, Nairobi, Kilifi? Is there a door-to-door testing? Why are we being given these sessions? And that should come out very clearly, so that even as we stay at home, we are staying at home knowing this is the plan the government has. And for the last one on human resource, I'm sure we will have a very insightful conversation once Professor Atwoli proceeds to give us his presentation. So I'll just move to invite our next presenter, who is Dr. Osoro. Dr. Osoro is the customer relations manager at AAR Insurance, and he will be speaking to us on the insurance perspective with respect to access to insurance services amidst this pandemic, and how the pandemic has affected their inflows and outflows as far as revenue is concerned. So Dr. Osoro, you have 15 minutes. Dr. Osoro?
Hi, can you hear me now?
Yes, we can. Thank you.
Problems with technology, and the doctors are not the best. I'm impressed by how Daktari was able to get things going very quickly. Good morning. My name has been given. I'm Dr. Osoro. I'm the Customer Experience Manager. Can you hear me? Oh, okay.
Yes.
Okay. I'm Dr. Osoro, Customer Experience Manager at AR, and I've been at medical insurance now for close to 15 years, and we are going through a very interesting session at this time. I have a small presentation to just explain how the medical insurance works, and what we are seeing and what we anticipate to see, and what we are planning to do for that. I think I can share my screen. Okay, give me a minute. Yes, I think we can see that. Winnie, can you see?
Yes, Dr.
Yes, we can.
Good. So now I'm just going to start by giving an explanation of how perhaps the insurance model works, so that we can understand. Insurance model in a nutshell works where people pool their premiums together. We come up where a few people come together, then we put our premiums together, and then in the event that some of us get an illness or some accident, we are able to pay their claims, which will be larger than what they actually brought to the table. Now, it works on the assumption that first and foremost, and the most critical thing, is that the group will need the cover at a time that is not known. So there's an unforeseen risk, and that their small contributions will be able to manage a small group of people getting an illness. So it is a small contribution by many people to take care of big claims, but by a small number of people. So that's the way that the insurance would work. I think many of you may know that. Now, the trouble comes when a pandemic comes in, and pandemic in definition is that illness that is widespread and is affecting a large group of people at the same time, or a large group of people and has crossed the borders. Now, then insurance becomes a disadvantage to a very, very large extent, because then you have the group of people that you have, then many of them will then need to access the funds. So you find that then that number begins to overwhelm, just the same way the COVID would then overwhelm our health system. Then it will start to overwhelm the capability of the insurance players to be able to offer cover. And hence you find that in many jurisdictions that insurances would not be able to cover pandemics and all that. So that is something that is put in just to ensure that the companies don't collapse. Now, if you just look at the premiums, when you pay premiums, they are divided into 4 basic areas. That is where the money goes, into 4 basic areas. Now, the claims are the medical bills, so, and they take the largest bit. Now, historically, 71% is one of the best case scenarios you'd have, where 71% of the money that is paid goes to pay claims. But most often, and in many companies, you'll find that this number grows and becomes for example, like outpatient sometimes gets to 90s to 100%, meaning whatever premium you pay goes directly to paying the claims. So it is from one side to the other. Now we have management expenses, which is the salaries for the people who work there, like myself, so that I can go at least and eat at home once I work from there, where our phone bills, our rent and whatever, we have to cater for that, following up with the medical doctors, and just working. The working expenses would go anything from 18% to about 15% at the best, to the best of my knowledge. Then the people who sell the insurance also have to eat something, and as per the law, the regulator, they have to be given 10% of the premium. Then hopefully, and if possible, for those who are the owners of the business, the shareholders, then perhaps, and which doesn't happen in many scenarios, perhaps they'll have a profit of 1%, perhaps. And this is the best scenario I've seen in ages. So, but many times the profit is down to 0.1, 0.2%. So that is how the premiums are placed. Now, when the claims, and as we've done calculations right now, which obviously at the beginning of the pandemic, it's more rough, it needs to be refined here and there, but it shows that this percent, the 71% may rise to almost 110% of premium. So we are looking at possibility that if we continue to cover that, it may cause a lot of havoc to the insurance companies, and we also fear that perhaps some of them may have to close down if they take such a huge hit. Now, there are some things that are complicating the situation, and I think maybe I'll just bring it out. Some of the things that are causing a lot of headaches. Yesterday, I was just discussing with providers and my team on how to handle the COVID cases, and some of the things that we are beginning to see that will complicate everything is, firstly, there's a lot of uncertainty, there's a lot of anxiety. I think you've even seen disorganization. There is quick shutdowns of everything, and then slowly people are becoming fatigued. Yeah? You remember when we started off, everyone was washing their hands religiously everywhere. Now, even masks, you find some have put on their shoulders, some are in the bags. So people are beginning to get tired of the initial measures that we put. So even that flows to even the work that we are doing, the partnerships that we had started on trying to manage the COVID. People are beginning to get some malaise. People are getting tired of staying at home. I think all of us are beginning, even the sanitizers are less nowadays all over. So everything from work, there's a lot of disorganization, anxiety, uncertainty, malaise, and that's causing a lot of problems to us, because we need to plan, and we need certainty for us to plan to see how we can cover. There's also a poor coordination, and maybe we shouldn't just look at our own environment. Even look at Europe, look at US. There's a lot of poor coordination between parties concerned, between the doctors, between the government, the private sector, the supply chain. I think Daktari had showed that, be it counties, even in houses. I'm sure there's poor coordination. It's just that people are not saying. I'm sure even in our houses, coordination is not as good. But there's a lot of poor coordination between different parties, which is making it worse. And for us, we also rely a lot on data. For us to be able to extrapolate and say, we'll be able to cover to this level, we'll be able to charge this amount, we'll pay out this amount. We need a lot of data. From simple data as what is the possible cost of PPEs? What is the cost of the test? What is the cost of a case? What is the incidence rate? Even the testing is not good enough. So for us, we are very disadvantaged because we are not getting the data, or the data that is being given is not being shared widely. There's also hidden data. There's talk of hidden data. I think some of you have heard the stories perhaps China hid the data and all that. There's also possibility that data is not being shared properly or is being shared inaccurate data. I think in your various WhatsApp groups, you have even heard that if you shower in a certain angle, you prevent COVID. So there's a lot of data that is flying that is not making the situation better for us. Luckily for us, we've not experienced a huge hit yet because the incidence rates have not been high. People going to hospital have not been many yet or reported. So we are still in the nascent stages of this. So the data is still very little, but we need other data to make calculations. We're also working in a very different environment. 95% of my team are working from home. Your child is jumping on you. Very soon you'll see my people walk into the room as I'm doing this meeting. This is also affecting business because then we are unable to meet our clients. We are unable to have health talks with our clients. We are unable to review their satisfaction. So it's very different. And online, for example, some of us just even setting up an online call is a lot of drama. So we are having a lot of such challenges due to the different work environments, making our business a bit hard. We've had to assist our staff members to work from home, give them portable computers, so that increases the cost also to us. And the biggest fear is because of reduced business worldwide, there'll be reduced purchasing power and thus reduced premiums. Now, the premiums are what we use to pay the claims, but the premiums will be reduced. So our capacity to care for more people will be greater hampered by this, not only by the disease itself directly, but also the economic effects that follow. And we also have a reduced capacity by our different departments all over, from the security department, from the healthcare department, from even our own people in the office, just to handle such a thing, because we've never seen it before. So to everybody, this is new. We don't know what to do. We don't know how to handle things. So we have a reduced capacity in terms of just handling or moving forward. And then the biggest thing that we are fearing is the loss ratio. I think just to explain what we call the loss ratio, the loss ratio is this percentage that is the amount of money, the ratio between the claims and the premiums that we receive. Now, we are worried a lot by that. We think that it could be almost 11 to 31% extra, depending on how the industry decides to cover the cases and the extent to which PPEs and testing will be done or available. Yeah, and especially because most of our members are affluent and they live in urban areas, and upper respiratory tract illnesses would really spread the fastest, especially there. If we get to a stage where the pandemic overwhelms our health system, even us, we are part of the health system. Actually, I don't know why we've been left out in the coordination, because we pay close to 70% of bills, and to some providers, we are the ones who pay 90% of the bills. And if we continue to offer support at the point where the pandemic overwhelms the health system, we will also be part of that group that is overwhelmed. We also have a lot of our people have got other illnesses they are living with. A lot of our people have poor nutrition. I think the idea is poor nutrition, not lack of food. Poor nutrition, we're eating poorly. There are people who are coming up just wanting to have the test done. We may not take care of all of them because of capacity. The number of investigations in hospitals are going to be more, definitely. And then when people pass on, they are also due to be paid benefits, the last expense claims. We might have problems with disposing of the people that we've lost. And so we are having, these are the things that we fear will come and make and disrupt our operations completely. But on the brighter side, there are things that we think will help us, and hence we are upbeat that we'll be able to manage this. Working online is a beautiful thing. We are here in a meeting, and I know there are many people listening to me. They've never seen me, but we are able to discuss. So it's changes. There are good changes that are taking place. For us, online is cheaper from a company perspective. It is also faster. I can get out of my bed in pajamas and check into a meeting like this. I don't have to take a shower and take a matatu and Uber and whatever, and I sit on the lobby, get some tea, then before I start speaking. Right now we would have been eating sausages, I hope, if we had this meeting in a town hall. But it's cheaper for us in terms of resources. Through this stage of this pandemic, we've been seeing that there are newer and effective guidelines that are being released every day, how to handle people, how to handle the disease, how to handle insurance, how to handle financing. So people are putting their minds together, and we are beginning to see the light. In Africa, there's talk of a smaller elderly population. There's a smaller number of people with chronic illnesses. Yeah, the government of Kenya has some very nice preventative measures. Some of us may not like the curfew, but I think it's helping in flattening the curve. And for some reason, whether it is data, whether it is, there are so many postulates, there are things that have been put across. Whatever it is, there is lesser morbidity and mortality to this. So whether it is data that's not coming, we are not sure. It's just the Lord, so maybe the Lord just likes us Africans. So something is helping us. Something is helping keep the numbers low, or maybe it's just me being just optimistic, but something is helping. The government of Kenya has given some facilities for quarantine, for testing, which is helping. And then funny enough, only very sick patients are going to hospital. Many people are avoiding coming to hospitals. And I'm talking about private hospitals. I'm not sure about government very well, but I would think it would be more or less the same, but for private, it's less. So even the claims for inpatient and outpatient is reduced. It's going to almost half. Also, the preventative measures, just washing our hands, sanitizing, staying at home. The claims from diseases of diarrheal diseases, chest illnesses, accidents, occupational hazards are also reducing. Car accidents are less because people are moving less and less. Moving around patients is also less. So there's some good things about that. I even saw that elsewhere animals are moving around better. The sea is getting cleaner. So there are good things that are coming up to help us at least manage this. And there's greater cooperation between providers, hospitals, insurance companies, payers, as we go through all of this. Now, so that you don't get tired of my voice, I think I'll just come to the broad ideas that we are working on in terms of moving forward. The first thing is that we should start looking at long-term approach to this illness. It's not a swarm of locusts. It's not going to fly away. It's going to be here for a while. And we hope that treatment or vaccination would come in and try and reduce the number significantly, but we need a holistic and long-term approach. It will be here for a while. We need to collect data in a better way. We need to manage it in a better way, and we need to get data to everyone. Even the person who's at home trying to quarantine, we need to get them the right data so that they can make the choices. We also need better knowledge on the disease, how it's to be managed, so that the healthcare professionals can be more effective, especially on cost, so that we reduce the need to overdo on one sector and not have resources to cover the other. We need to cooperate, all of us, the health professionals, the public, the payers. We need to work together. Once we work together, things are easier. I think we've had a lot of consultations over the last few weeks with different players, and we are finding ways to move, which is a good thing. And people need to adjust around what is happening, get preventative measures, and start returning to a normal way of life. People need to start making money. Economics and healthcare have to move together. We need to get back to working. We need to even work harder at this time, so that we're able to support each other, support ourselves. And as insurance, we are working on models to ensure that we support our clients, because the clients will still be there for them. We are going to give more and more support as we continue. I think I hear the questions will come later. I think I can stop at that. Maybe my voice is also not so good. So Winnie.
Okay, Doc. Thank you so much. Yeah. Thank you so much for that presentation. So a quick one for Dr. Massey and Dr. Osoro. If you click on the chat icon, I can see people are already asking a few questions. So you can be looking at that as we continue the presentation and preparing your answers for them. And then when we reach the plenary session, each person will be given an opportunity to respond to the questions people have asked on the chat. And to anyone who has a question, you can just type it on the chat, and then we'll get the presenters to respond at the plenary session. So to Dr. Osoro's presentation, I believe most of us now are more comfortable understanding the issues your insurer is experiencing in the during this pandemic. And also it is coming out clearly that as an insurer, speaking for AAR, they feel that they should also be incorporated in the discussions that are going on as far as this pandemic is concerned, especially because Dr. Osoro is indicating that they sort out bills as high as 90% for their insurers. So I think that is one thing that we can also discuss as we continue. So we will just proceed to our next presenter. Our next presenter is Professor Lukoye Atwoli, and he's going to speak to us on issues governance, financing, and human resource, and how COVID-19 has affected these three areas, owing to the fact that these three areas are very important even as we try to handle this pandemic that is here. So Dr. Lukoye will take us through that for about 15 minutes, and then we'll move to the next agenda. So Prof, 15 minutes.
Thank you.
Karibu.
Thank you very much. I've really enjoyed listening to the previous presenters. A lot of the things that I would have spoken to, I think they have covered very well. But I'm just going to make a brief presentation that covers the area of governance, a brief look at financing, and a brief look at the status of human resources for health. And then I will spend a little bit of time looking at what COVID-19 has done to those. So I'm going to try and share my screen as well. This is where we now know who is who in this. I don't know if my screen is visible, Winnie.
Doc, where's Prof? You see?
I'm trying to.
We can see you. We can't see the presentation yet.
Okay, let me try and fix that.
I'm happy to see I'm not the only one with the technology challenges.
No, you're not the only one. This is a challenge to
Prof?
the rest of us. Yeah.
I thought it was COVID.
Maybe.
Prof,
Yeah.
do you want to
Yes.
share it with me?
I share it with you. Okay, let me send it to you. Or,
So I can try sharing it from my end.
Dr. Sorry, you're doing well.
Sorry?
Doctor, you are doing well.
Yeah. I'm so happy. I thought I was the only one looking bad, and I've used this for the first time today. Thank you, Winnie.
I'm also using it for the first time, so I'm struggling to. Yeah, there it is.
The problem with doctors, we just don't know much.
We know,
You know a lot.
Yeah.
We know a lot about one thing, but nothing else.
So it is sending, Winnie.
Okay.
As it does that, I wanted to just first of all begin by pointing out that it is my opinion that health systems are established not necessarily to handle the usual day-to-day things, but to handle pandemics such as this one. Okay, is it visible now? I've shared it with you, Winnie.
No, I wanted you to send it on my email.
Okay.
Yeah, so I can share it for you. Sorry
Right.
about that, guys.
No worries. On email, there it is. So I'm going to send it to your email right now. Yeah. Okay, so I've sent it to you. As it is set up, I think I just want to point out there are very few slides, and they will just cover the subject of my presentation. So I wanted to point out that firstly, it is my family held opinion that health systems are set up to deal with situations such as what we are going through. People create health systems and fund them in order that A, they are protected from outbreaks such as this one, and so that if it does happen, then we can handle it without disrupting the rest of our economy, without disrupting the rest of the functions in the system. So when you find that this is failing, then it is a failure of the health system's preparedness to do what it is set up to do. I would then move on as Winnie sets up. I hope you have it, Winnie, now.
These technology challenges.
Yeah, let it continue, but I will just speak to it as she sets up, because I don't think it's as important as, I guess, the message and time for question and answer. I'll begin by saying that our governance system in health changed starting from 2010, but effectively after 2013, the county's government system effectively took over the health docket, which is shared between the national and the county level. At the national level, the national government is expected constitutionally to deal with policy as well as the national referral facilities, and as well as providing support for counties to implement the health function. And there are certain circumstances, as has happened in Nairobi, where these functions, after a process of negotiation, can be transferred between the two levels of government. On paper, that is how it is set up. In practice, it has been pretty fragmented. There have been different ways of handling human resources for health depending on the county. Sometimes, depending on the county, wealth, and sometimes depending on the county's management structures and governance. So that has been a differentiating factor across the counties. While the right to the highest attainable standard of health is guaranteed in the Constitution, its implementation has largely depended on the governance structures in the county and the amount of money available to each county. And finally, on governance, I think we have seen a lot of, yeah, thank you, Winnie. Can just move to the next slide. We have seen a lot of labor relations issues at the moment. Yeah, are you able to move it to the next slide? Because you're the one controlling. Yeah. We've seen a lot of problems in labor relations. So this is the structure this is the structure of governance in the health sector in Kenya as provided for in the Constitution, where the national government is dealing with health policy, regulation, national health facilities, and capacity building for the counties. And then the counties take care of everything else from primary health care all the way to the county health facilities and sub-county facilities. If you look on the right, you'll see that services are divided from community health services through primary care services to county referral facilities, all the way to the national referral facilities. And as far as services are concerned, then the national referral facilities are the only ones being run at the moment under the national government. This next slide. So then we spend a little bit of time looking at the structure of financing for the health, for the health sector, and this is from a report that was looking at the growth in the financing in the health sector from 2002, when we were spending around 15 million shillings. Is that 15? Up to now, where we are spending around 200 billion shillings on health, from 15 billion shillings in 2002 to 2018, when we were spending around 200 billion. These are actual expenditures over the years. And if you looked at it as a fraction of the budget, then you'll find that it has remained pretty steady at somewhere between 4 and 6% of our budgetary allocation over the years, putting together county and national. And if you look at the next slide, you would see that at the county level, the expenditure on health has stagnated at around 30% of the county expenditure. Winnie, you can move to the next slide. Yeah, so you can see that since 2014-15 to 2017-18, it has grown from around 21%, but has remained at around 30% over the recent years. And you understand that at county level, the bulk of the services being offered at the county level are health services. And so when the allocation is 30%, you need to weigh it against what is expected from the county. And the largest function in the county is health service provision. If you look at the next slide, it tells you about the mix of services that are available. And I was happy to hear Dr. speaking about what they're doing as insurers and what their concerns are. You find that Kenyans access healthcare based on the weight of their pocket, because most of the health service access is out-of-pocket finance. Insurance contribution is not as much as one would like. And those who have some wealth or have insurance then would access the high-end private facilities whose main value proposition is quality. They say that you'll get up-to-date treatment, state-of-the-art care, patient-centered nursing, and care that is integrated. So you get everything that you need based on your ability to pay. On the other side, again, in private facilities, there are low-end private facilities, which you will find even in low-income settlements, and their main value proposition is access, because the public health system has not penetrated to those areas, and where it is, the services are not considered adequate. On the other side, now, if you look at the public health facilities, their main value proposition is affordability. That the services are subsidized by government, so you pay less, and then a broader range of services are available in the public health facilities. So that is the main draw to the public facility. And in many places, these public health centers and so on are the only health facility available. And then finally, at the community health level, where we are using community health workers, in some places, I think we are still insisting that they remain volunteers. These are really public health interventions, which would now prove decisive in a moment like this, peer-to-peer interaction, where people who are trained, but then you live with them in the same community, would be discussing how to prevent spread of COVID-19, prevention of cholera, healthy lifestyles, and so on and so forth. So that is how Kenya's the health services are fragmented. One of the studies that was done some time back suggested that when people were asked where they access most of their services, the first answer for many people, 28%, only 28% indicated that the first thing they would do is to go to a health facility. And an almost equivalent number say they would go to a herbalist in the village. And about a third indicated that they would go and see a traditional healer as a first thing before they start thinking about going to hospital. And this just tells you about the kind of access to health services that we have in this country. Now, if you look, the next slide is just the mix of human resources, a brief look at how many health workers we have. Winnie, you can move to the next slide. Yes, so I mean, right now we are probably doing about, this is just coverage for purposes of UHC. We are not even at 60%, and that is, we are aiming to go as high as possible with the UHC, which had started and has now been massively interrupted by this COVID-19. Please move to the next slide so that I finish the human resources health. This is the mix. As at about 3 years ago, the numbers have increased slightly over the past 2 or 3 years, but these are the ratios that you see in the system. There are about 10,000 registered medical officers, just over 1,000 dentists, pharmacists, 2,000. So those are the numbers that we are talking about as far as the health workforce is concerned. If you look at the average ratio per 10,000 population, we're doing at about 12.5 per 10,000 population, against ratios that are expected to be somewhere above 40 per 10,000 population. So we are still struggling. We are ranked very low by the if you look at the access to healthcare metric, we are ranked somewhere around 140 out of 190 countries in the world. Now, having said that, then I would look at COVID-19 and how it has impacted these metrics. But first, just to start with a brief overview about what is happening in the country. One thing that you will note is that the daily briefings have been giving you summary statistics based on how many people have been tested, how many people have been found positive, how many are dead, how many are in critical condition, and so on. And I've had people talk about projections and saying that we are doing very well because the numbers have been kept down. The projections that we have available to us, which the Ministry of Health used to give the figures of 5,000 and 10,000, there was a worst case scenario that projected that between March and February of March this year and February 2021, that is when the numbers would be peaking, and the peak need would be somewhere in February 2021, where we would be needing over 300,000 beds to take care of patients with COVID-19, and of about 100,000 would require ventilation at that time as the projections were being done. And this was based on the worst case scenario, where they estimated that in that period, up to 88% of the population would be infected. And so the numbers would be so high in that regard that even if a small percentage of even 5 to 10% required intensive care, then the absolute numbers would be very, very large. There was one assumption that was made when these projections were being calculated. And the main assumption was that we would be able to test large numbers of people in order for us to be able to determine that 88% of the population is infected. Since mid-March, when this testing began and when we reported the first case, up to now, we have done less than 20,000 tests. And of those 20,000, some of them are repeat tests for those who tested positive, because they have to be tested several times before it turns negative and they can be released from the isolation center. So if you have done only 20,000 tests, you cannot, unless it is an infection with a 50%, infection rate or something, you cannot expect to have even 10,000 people testing positive. So this is the first problem and the main problem, that no projection is useful. No projection can even be appropriately done if you're not testing and if you do not know how many people are infected at any given time. So having said that, then I'll look at the effect of COVID-19 on our governance structures. You remember we talked about how our health system is organized. When COVID-19 started, the government set up a coordination mechanism, the National Emergency Response Committee, which brought together several ministries and brought also on board the county government structures through the Council of Governors. And this is the apex coordinating agency in the country. Obviously, it is made up of politicians and people appointed as ministers, whom we all know. Below that, then there is a task force that was formed, operating mainly under the Ministry of Health, which has the experts who are supposed to look at the modeling, but also to look at the operations on a day-to-day basis, rapid response, testing, isolation and quarantine for people who test positive. So that is the structure that has been set up now. And that structure then is supposed to work seamlessly through the security agencies, the Ministry of Health, Finance, and so on. But obviously, as we have seen, there have been a few challenges, given that whatever comes out of the task force is still supposed to be filtered and interpreted and then implemented based on what the people who are implementing understand. And we'll see some of the problems that are associated with this. As far as financing is concerned, we operated as usual based on our usual financing mechanism. So when we decided that we need certain amounts of money to buy PPEs, to buy testing equipment, to prepare our hospitals, we prepared a budget and submitted it to Parliament, and then waited for Parliament to make the necessary approvals. And as you know, Parliament was also working from home and having difficulties operating. And so it took a long time, according to the ministry, it took a long time before they got approval to spend money on buying kits and buying these PPEs and so on. And this has led to the current situation where all these things are in an acute shortage. Now that the money is available to purchase kits, the kits themselves are in short supply, because those who ordered them earlier and those who had money ready in the beginning were able to mop up most of the existing kits, and all that were being manufactured were being mopped up by those who had money ready. So clearly our financing mechanisms for health emergencies were not set up to deal with a pandemic of this nature. Another problem with financing is that there is very little transparency on the fund use. And I will give you an example that people who are contacts of people who tested positive are being taken into quarantine, and then they're being asked to pay for it. People who test positive and are being taken into hospitals, including public facilities, are being asked to pay for their care. And one would expect that in a pandemic situation, some of the resource mobilization would be geared towards dealing with situations like this, where you are taking somebody from their home for public safety and keeping them away from the public, but you are expecting them to pay for themselves. So this creates a lot of problems in pandemic control, because then people become reluctant to go into quarantine if they're going to pay for it. And people would run away from anybody who is coming to test them, because if they test positive, then they have to find the money to be cared for. On human resources for health, we had a shortage, as indicated here. We had very few health workers in the system in the first place. And then we set up mechanisms as usual, operating under a business as usual model for recruitment, where there were squabbles between county and national government about who is going to recruit and who is not going to recruit. And so the recruitment process has been very slow. And after recruitment, these people would need to be trained. The process will be slowed down. And then there is inadequate PPE for the people who are in the system already and the people who will be recruited. We still do not have adequate PPE despite moves to have local manufacturing involved. And a big problem in human resources for health here is that there were counties that had disputes with their health workers, like Kirinyaga, I believe, and like Kipia and so on. They had problems with their health workforce. They had fired some people. They had stopped paying salaries for some people, and so on. And these problems have continued even during this emergency. And this will hamper the ability of those counties to deal with this pandemic should it reach those areas. But finally, on operations, as has been mentioned before by my colleagues, there has been an unclear plan of operations. When we instituted movement restrictions for 21 days, the expectation was that during that period of restriction, there would be widespread testing within the areas which we are calling hotspots, where we are preventing people from coming in, so that we can test and get a true picture of the spread of the pandemic within those areas. As you have seen, we were not able to do that. We have done less than 20,000 tests across the entire country since the beginning. And so at the end of those 21 days, we were not any closer to the truth than at the beginning of those 21 days. And even with the expanded 21 days again of movement restrictions, we still are struggling to test people so that we know the shape of this monster, so that we can then prepare and advise people appropriately. Without testing, even the health workforce will not be able to predict and plan for care. I have mentioned that quarantine has been poorly handled. It has become a security issue where you break the law, you are sent into quarantine instead of going through the legal justice system. And this has increased stigma towards COVID-19 and towards people who are suspected of having COVID-19. Our messaging has been off a little bit, where we are telling people, if you suspect this person has been exposed, you call this number and so on and so forth. And so in conclusion, I think I would say that in handling COVID-19, we should endeavor to plan for the long term. We should strengthen our health system so that it can take the shocks of epidemics and pandemics when they come, even while providing continuing care. We have seen disruption in continuing care for people with chronic illness like hypertension, diabetes, mental illness, cancer, and so on. They have been disrupted because attention has shifted towards the COVID-19 response rather than continuing care and identifying specific places where people with COVID-19 can be treated. So we need to plan for the long term, because health systems are set up or should be set up to deal with pandemics. And if they can be set up to deal with pandemics like this one, then they will be able to handle everything else that is thrown at them. Thank you very much.
All right, thank you so much, Prof, for that presentation. I think it is now a bit more clear that speaking to what Mercy had said, and now Prof is also mentioning it, the government needs to have a plan. Because as it is right now, back to the secession that we were talking about earlier during Mercy's presentation, and even Dr. Osoro's presentation, there is no clear plan that has been given even as we are put under secession. So that comes out clearly throughout all the presentations. And then for Professor, again, there is definitely underfunding within the health sector. And this is an issue that did not come with the pandemic. This is an issue that has been in existence, and we've had medical practitioners making noise and trying to get this issue of underfunding addressed. And it has definitely been exposed even as we try to handle this pandemic. So linking it to planning for the long term, planning for the long term would entail a lot of financing for access and even for human resource. So these are issues that are coming out to play, and even with the shortage of healthcare professionals, again, an issue that is not coming with the pandemic. This is an issue that has been there, and we've seen medical practitioners asking that more health professionals be employed, and now the pandemic is here, and of course, these are issues that now we have to handle. But even as the government tries to handle these issues that have been exposed by this pandemic, we cannot look at them as just the pandemic period. We have to give it a futuristic angle and then try to look at it in terms of, should we be hit by another pandemic such as this? Are we, based on what we've experienced from this one and our learnings, how then will we handle the new pandemic based on the long-term planning that we will have for this pandemic? So that said, I'd like to bring my colleague John on board so that he can take us through the plenary session. Then we can he can guide us on who goes first, and then we can proceed from there. So John, we have about 10 minutes that we can use for the plenary session, and then we close up. John? John?
Yeah.
Okay.
Yeah, thanks a lot, Winnie. I think you've done a good job in terms of trying to summarize some of the things that have been shared by Dr. Mercy Korir, Dr. Jared Osoro, and lastly, Professor Lukoye Atwoli. I think before I invite our participants for the plenary session, just to add in terms of summary to some of the things that you mentioned, I think what I picked from Dr. Mercy, the one thing that I picked from Dr. Mercy is the issue of data. The fact that the health system is already burdened. It will be interesting to see in the next 2, 3, 4 months the data on, for instance, number of health deliveries in health facilities and number of health deliveries attended by skilled providers. So it will be interesting to see those kind of statistics, because we've been doing well on that in that regard, but then it would be important or interesting to see whether that's been eroded due to this situation that we are in. Then for Dr. Jared Osoro, the one thing that was not clear is that he mentioned that the issue of claims may rise, but at the same time, he also mentioned that there are reduced claims from other illnesses, both inpatient and outpatient. So that point was not very, very clear. And of course, for Dr. Lukoye, Professor Lukoye, he has given us a good picture of how the health system is, the fact that already, even before the pandemic, the system was quite limited in terms of human resource, as well as in terms of infrastructure. So the fact that what can we do as a country to ensure that given the limited human resource that we have and the burden that this pandemic is exerting on this system, how can we do in terms of, or what can we do in terms of proper or efficient allocation of resources to ensure that we respond to this issue better? So those are my quick thoughts around that. So what I will do is to welcome questions, but I'll just quickly mention, before I do that, there are some that were shared on chat, so I'll just mention those. Some were directed to Dr. Mercy, so Mercy, you can note this down. From Charles Mudama, there's a question on that some county governments are already giving, he didn't mention which ones, already giving health workers allowances, but this received some negative reaction from the national government. Maybe you can comment on that.
Okay.
Yeah, so I'll give you, I'm just raising this quickly, then I open it up for 3 questions, and then I will allow the speakers to respond to this. Then the second one again to Mercy. So there is a question of, yeah. Yes.
Okay. John,
Yeah.
I'd picked them out from the chat.
Yes, yes. Oh, you had already picked them out.
Yeah.
Okay,
But
so if you had done that, because I'm just going through them. So let me allow 3 people to raise or ask whatever question they have. Then you can, any of the speakers can respond to the questions that have been directed to them, in addition to those that have been picked. But I'll also mention those as we go along. Okay. So please, for anyone who has a question, so let me just allow for 3, then you can have another round. Anyone who has a question, please, you can unmute your mic.
Thank you, John. Thank you, John.
Yes, Duncan. Yeah.
Yes. Thank you for the panelists for the presentation. My question, I'll just shoot 2 questions. I think one is for Mercy and one is for Dr. Mercy and one is for Professor Lukoye. My first question is, we do appreciate that even before the pandemic, the health sector wasn't in bad state in respect to issues of financing, etc., etc. So my question would be that there are these knee-jerk reactions that we are getting from the government. To what extent are these responses and measures put in place by government going to eventually help in addressing the issues that were bedeviling the sector even prior to the pandemic? And then secondly, my last question would be, in more specific terms, and this one in more specific terms, what would be the impact to particularly the marginalized sectors of our population with respect to the pandemic? To what extent are these affected, and to what extent are the measures put in place by the government go along in remedying these challenges? Thank you.
Hello. Hi, my name is Maureen Murenga. I have two questions. The first one is around the slowing down of response of other epidemics. We know we have been responding to other epidemics such as HIV, TB, and malaria. And for HIV and TB, the moment we slow, the epidemic grows up. Is there a group that is working on finding innovative ways of service continuity for other epidemics amidst the COVID-19? And then the second one is around creating efficiency. I know we are not very, the Ministry of Health is not very transparent on resources they have got for COVID-19, but we also saw the budget that was presented yesterday and some of the areas they spent on, such as 15 million for printing and stationery. Is there a way that they can be taken accountable in terms of creating efficiency, but also using resources in areas that can create an impact? And then finally, it's around stigma. We have seen people buried hurriedly and sometimes in a very not very human way because they're suspected of having COVID-19, and then later it is discovered that they really didn't have COVID-19. So like the boy who was buried yesterday, he had TB. How is that going to affect people who have other health conditions such as TB and pneumonia and malaria in accessing services for fear of stigma? How is this going to be mitigated so that people don't fear leaving their houses if they have difficulties in breathing or having headache, because it would be assumed that they have COVID-19 even if they don't? Thank you.
Thank you, Murenga. The third one, the third.
Yes, hello. Hello.
Yes, your name, please, and who you are directing the question to.
Yeah, I'm Dr. Peter Kabuka. My question goes to the presentation of Ms. Korir and Professor Koya. There is this issue of mine is concerned about the staff. That is the number of healthcare staff who are dealing with this issue of COVID-19. As we know, being overburdened, and there's the issue of stress, overworking, and many other issues that comes with dealing with the issue. And as the Mercy said, we don't have clear system and coordination in terms of communication and operations and in supply management and decision making. So how this one I believe is going to affect the healthcare workers in terms of their marginal productivity. So if they are not being they are not doing it so fast in terms of training or rather moving other people from the other areas of like now other areas of surgeries and other areas of profession within the healthcare sector to come in and retrain so that they can be able to deal with this issue. Then what happens? Is there a system that is looking into that level so that they can be able to help the healthcare work system or other employees not to overburden or rather to have what they call mental health problems so that it can reduce their marginal productivity?
Sorry, one question directed to Professor Atwoli from Patrick Anam. And so the question is whether we have, given that we have a shortage of kits, testing kits, is there a possibility of a public-private partnership towards this in order to bring down to lower the cost? And then there's one more from Katindi, and this could be, it's open to any of the panelists. So Katindi is asking whether we have already started thinking about, or what is the understanding of the futures of the impact of COVID-19. So I will allow us to start with Dr. Mercy, then we go to Jared, and then of course Lukoye. Then we'll open it up for another round. So Dr. Mercy.
All right. Thank you for the good questions and the interaction on the chat. I think I'll start with the question on Maureen Murenga. Okay, she had many questions about if there are any groups doing other things on the other epidemics like TB, HIV, then on issues of stigma, TB, pneumonia, malaria. Yes, we are seeing a problem with this because I don't know if you have noticed that if you're in public and you sneeze or you cough, everyone just looks at you as if you have COVID. So I think there's a way we have messaged the issue of COVID that has directly resulted into stigma. And we also see by the CIR burial that we did not do any better. People who have been discharged to go home after being diagnosed with COVID are actually facing stigma in their local estates where they are because people there think that, they're still infectious or they still have COVID. So there's a lot of issues that we need to address when it comes to stigma. And I think for me, the best lessons to take are from how we handled HIV. And if you look at how we are handling COVID now, we are sort of handling it the same way we did HIV back in the day, where, HIV people, I think initially health facilities had a special ward for people with HIV and they're being treated as outcasts. And there are all of these things that made it difficult to live with the disease. So for me, I think it's not too late to learn those lessons and incorporate them quickly into COVID to realize that it is not a death sentence to have COVID or to be diagnosed with COVID, and that other things can still happen. TB, you can still present with a cough and fever. Pneumonia, the same. Malaria will still present with a fever. So there are other things that can still give you all of these things, and so they should not be stigmatized. Two is for our healthcare workers. They're also human like everyone else. They're also as scared as the rest of us. And healthcare workers being scared of attending to patients has a negative effect in that if somebody comes in with a cough and fever, they assume it is COVID, and yet it could be TB. So it directly has a negative effect. So how I see it is that all of us have to do something so that we do not suffer consequences from from our perceptions of COVID. And in terms of groups handling some of these things, I think the one that I've seen is somebody who's offering sort of emergency services for women in labor post-curfew hours. And I think that was commendable. But our healthcare system should have been set to respond to this. As Atwoli said, the healthcare system should be set up to respond to epidemics and pandemics. And if it was so, we wouldn't even be having this conversation because we'd already have a system that, addresses all of these concerns that we have. On the chat, Martin Ochola was asking about washing hands in arid and semi-arid areas and informal settlements. So these are the challenges that we are facing across board. And that's why you see there are private enterprises, there are private companies and individuals who are going into the informal settlements to provide them with water. Initially, people were doing sanitizers, but clearly it wasn't a sustainable practice. But now people are trying to supply as much water as possible into those informal settlements. And we know that soap and water is the best way is the best way of making sure that, the virus has been gotten rid from your hands. On the issue of having PPPs to reduce the cost of kits, it's probably an area that can be explored. But here, I do not think, this is my own personal opinion, I do not think the problem is really the cost, as we can see, and you said rightly, we spent 15 million on printing papers, on buying printing papers and actually printing again. So I think it's just a matter of prioritization and seeing what can go where to address what we need, one. And then the other issue of testing is not even just the kit itself. You find that there are lots of logistics before, from getting the sample to getting it to the lab, and then from getting the result out to the person and how it's handled. So I think that whole diagnostic chain is what needs to be addressed. It may not just be looking at one thing and we are looking at the cost of kit, but the entire spectrum of the diagnosis, from actually taking the sample all the way to testing. So there's a lot that can be looked at. On the other issues, I think Prof can address better, and on the coordination and efficiency and productivity.
Thank you, Dr. Mercy. So let's move on to Jared, Dr. Osoro.
I was very happy that I have very few questions. I think mine was very clear. I'm so happy. Dr. you should try my way. I think I just went. I went through some of the chats and trying to see what the comments and some of the questions. I'll try and just go through them quickly. I don't think I was asked anything, so I'm happy. It's a good day. First, I think let's not also be hard on ourselves. Unpreparedness for this pandemic is worldwide. Remember, all jurisdictions, I don't think there's anyone who's having a good time. Even the positive ones that are being brought out, there's been significant morbidity, there's been significant mortality. So not very many people are unprepared. So let's also have that in mind. I think it's the wider human poor health seeking behavior worldwide. I think that is the main problem. And maybe we need to look at ways of strengthening health sectors, as Prof had said, to handle not just day-to-day illnesses, but also pandemics. Someone had asked that the curfew could be leading to lesser claims. Yes, I agree. Partly because people cannot go to hospital directly, that's a direct reason. But there's also the reason that the curfew and restriction of movement has reduced also accidents, has reduced eating out, the GI illnesses we get from our mutura has gone down. So all that comes into play. Now, someone said that was asking about insurance cover, whether it's covered or not. I think, yes, the insurance companies will offer the support, but remember, initially, even as the COVID came into play, the initial management of COVID was especially through the government centers, and the same thing, we offer the support there. And as the management of illnesses begins to be strengthened in private sector, you will be seeing more and more support coming from the insurance company. So there is something that's being worked on, just like every aspect of the healthcare is working on a way of handling COVID. So every player in the market, from insurance, from hospitals, from providers, I think you even realize that even ENT doctors, dentists, specialists, all of them closed their clinics. So, and they are going to start coming back. So everyone is just taking stock, and I'm sure there will be support in that area. I think it's our moderator who had asked that it was not clear between, I don't know if someone is falling down, but hey, someone asked if it was not clear how the claims are going down, also increasing. Maybe I could try and explain. When we got our first case, there are different measures that that were put in place, and at the same time, people changed their lifestyle, and which included lesser visits to hospitals. The specialists also closed their clinics. Some hospitals also closed down some areas. Now, that definitely reduced the number of claims coming to us directly. Now, after that, as the pandemic begins to get hold in Kenya, then definitely, or we think, the claims will then begin to rise, as we have seen in other jurisdictions. Just to finish, someone asked if we can, Daktari Korir, someone said we should speak to a larger audience. Maybe Daktari is a politician, may work with her well. For me, I think we can work through such forums. We educate people, and we also ask for your help in disseminating the right information to others. We ask you to also help give the right information to people. And then lastly, someone had said they cannot see me. I'll assure them it's a problem with the camera, but I am handsome. I can just assure them that. Thank you.
Yeah, thank you, Dr. Osoro. So let's move on to Professor Atwoli.
Yeah, thank you very much. There are numerous questions, and I think following on Dr. Osoro's observation, it is obvious then that I wasn't as clear as he was. So I will try and be better. I think the first broad question that has been asked is, what can we do to improve our human resources for health situation? What needs to be done? I'll begin, of course, by prefacing it and saying this is a mantra that I repeat everywhere, that in Kenya, health is a shared function between the national and the county governments. Many people assume, and I hear some people still say that it is 100% devolved or whatever, whoever is in charge, but it is a shared function, and it's for a good reason. And so broadly, what needs to be done for human resources for health? There are many health workers who have been trained, who are out there, who are unemployed. I think that situation needs to change. We need to recruit massively. There are many nurses who are unemployed. There are even doctors, pharmacists, dentists who are unemployed out there. This needs to change immediately. Whatever needs to be done must be done to get them into the system. Having done that, then we need to increase our ability to train the key health workers that we have a shortage in. There are specialized health workers that we have very few of, including specialized doctors, nurses with specialized skills, and so on and so forth. this training needs to be expanded. To achieve this, we obviously must increase the amount of resources that are being allocated to the health sector for purposes of training, for purposes of recruitment and deployment, and for purposes of research. This also needs to change. There was talk in the past of having 15% of the budget used on health. I do not think we have a policy direction aiming to reach anywhere near there. And if that is difficult, then we must focus on a few deliverables, including having adequately trained, adequately resourced health workers within reach of a majority of our citizens. Importantly, to achieve this, we have to improve the coordination of the health function, human resources for health function. At the moment, there is a lot of confusion. The other day, people, like somebody has mentioned, health workers living in Kiambu County crossing over to Murang'a to go to work were being blocked because the governor said all his health workers live in Murang'a and so on. So this kind of coordination needs to be sorted out with a sense of the importance of the intervention that is being put in place. To my mind, it is very clear that all this cannot be done in a fragmented way. Every county looks at its human resources for health problems differently through a different lens. It is necessary, in my view, to have a coordinated mechanism that brings together all these eyes and looks at it holistically to say we have a shortage of anesthesiologists in the country, but in this area there are more in Nairobi than there are in Wajir. How do we deal with this? And that centralized mechanism can then deploy them appropriately. I am talking about something akin to a health service commission that works with counties and works with the national government to ensure that enough health workers are recruited, are trained, and deployed, and that they are equitably distributed so that all Kenyans have equitable access to health services in the country. Somebody asked about medical schools when I looked through the chat, and I will tell you that every year there are 1,000 new doctors entering the system, at least before this COVID disruption, before 2018. There are 1,000 new doctors qualifying, both from within the country and those who go outside to train, coming into the system. There are 1,000 of them coming in. Now, after internship, because they are sent out for mandatory internship, but after internship, now a vast majority of them are not employed. A vast majority of them are left to their own devices out there. It sounds strange, but it is true. How will the interventions being put in place now help improve our health system going forward? A very important philosophy of disaster response, especially in mass disaster situations, is that when you respond to it and build infrastructure and systems to deal with it, you should respond with an eye on the future. Something that we would call building back better. So whatever weaknesses were in the system that were exploited by the pandemic, we seal them now in order that we continue with a better system than we had before COVID-19. And so addressing the human resource gaps, addressing the financing gaps that we have identified, addressing the coordination and governance gaps that we have identified would be beneficial to the country post-COVID-19. And I would mention here that COVID-19 is not going to be with us forever. It's not like HIV. COVID-19 will affect the vast majority of us, but then the vast majority of us will recover and we will continue with our lives after COVID-19. So there is a life after COVID-19, and we should also start planning and thinking about a life after COVID-19. On the marginalized communities, we don't know anything that is happening in those marginalized communities outside of Nairobi, and even within Nairobi in the informal settlements. We do not know. Why don't we know? We don't know because we're not testing. And the moment we will have done, 200,000 tests, 300,000 tests across the entire country, then we will be able to say what is the impact of COVID-19 on those segments of society, and then we would be able to plan for services that then target those that we will have identified to be vulnerable. At the moment, we don't know because we are not testing sufficiently. Somebody mentioned the need for accountability, and I fully agree. Accountability has not been suspended by COVID-19. In fact, an emergency response calls for even more robust, innovative accountability mechanisms than usual. Parliament should play its oversight role. I don't know what's going on with the Office of the Auditor General. There have been issues about who is going to sit in that office. That needs to be fixed. And our utilization of these funds, our internal controls need to be deployed so that people do not take advantage of the pandemic to fleece the public. On the shortage of kits and PPP, I am a firm believer that in a mass emergency situation like we are in now, there should be no talk of private sector and I don't know what response. It should be a coordinated national response run by the national government as a threat to the integrity of the state itself. There should be no situation where a private facility somewhere has greater testing capacity than the government. And if that situation arose, I would be an advocate of the government taking over that private facility and using it for the disaster response until the disaster has passed, and then giving it back to that private facility. So we shouldn't have a situation where a private laboratory can test 10,000 people in a day, and the national government can only test 500 people in a day, and we allow that situation to continue. If there are barriers that prevent government from testing those 10,000 per day and allow the private lab to test 10,000 per day, then government should close down its operation and take over that private lab and test 10,000 people per day until this pandemic is over. So this talk of public-private partnerships in health, to my mind, is a profiteering idea where we are trying to profit off of a disaster, and that should be unconscionable. It is not something that I would be in a position to support. On health workers being overburdened, I agree. And the big reason why many are being overburdened is that they are few and they are being deployed to do very strenuous work right now in this pandemic over and above their usual duties. The solution, recruit more people and then have the health workers do their jobs in shifts that are reasonable. Usually what we have seen elsewhere is shifts of 4 to 6 hours, not more than 8 hours, because it's very uncomfortable wearing those suits that people have to wear when they're taking care of these patients. So you need numbers that allow you to do 4 shifts in a day, even of the clinical staff, the doctors, the nurses, the clinical officers, anybody who is having close contact with patients COVID-19 needs to be in a shift that allows them sufficient rest in between those tasks. We must strengthen the mental health and psychosocial support system for health workers who are frontline health workers. Right now, as in the past, mental health had been neglected. There is now a team at the ministry that is organizing this mental health and psychosocial support. I think it needs to be adequately resourced. We need to recruit counselors and psychologists to support this team so that health workers can be taken care of. Finally, future impact, the impact of COVID-19 on the future. I will begin by reiterating again that yes, there's a future after COVID-19. The vast majority of Kenyans who will be infected will be there in that future. They will not die and they will not have severe consequences. The goal of the intervention the goal of the intervention is to ensure that even if 10% of the Kenyan population gets severe illness, that at any given time, those numbers are low enough for the health system to be able to help them to get good outcomes. Having said that, then, if we do this intervention correctly, then Kenya will emerge from this pandemic with a more robust, stronger, innovative health system that will be better able to serve the needs of Kenyans than it has been in the past. If health becomes part of our national conversation, if health becomes an agenda item in all our campaigns in Parliament and in State House, then we will emerge with a stronger, better health system going forward. And somebody says, where is the voice of medics? I keep hearing this. Where is the voice of medics in this health sector? What are the doctors doing? What are the health workers doing? I will flip this question and say, health or bad health is not a problem for doctors. In fact, in any society, doctors have access to better health services than the general population. Bad health is a problem for the average citizen. It is the average citizen who should be advocating more for better health for themselves than asking the health workers who, despite the poor circumstances they are in, have better access to health services than the average citizen. Let us not put the burden of advocating for better health services on health workers, who are the tools that are being used to implement a good health system. The burden on advocating, the burden on pushing government and parliament and everyone else to allocate more resources to the health sector is on the citizen who votes, is on the citizen who speaks in public. Thank you.
Thanks a lot, Professor Atwoli. I know that we are completely out of time, but I will allow at least 2 questions. Any 2 questions?
Thank you, John. May I ask a question to Professor Atwoli? This is Howard.
Okay, thank you. Yeah.
Yes, my question is linked to now what we are seeing as a sort of a shortage of healthcare workers vis-a-vis the issue of task shifting. Then is now the time for us to revive that discussion and see how best we can implement task shifting, bearing in mind people like community health workers who can take up a load at the lower level?
Okay, thank you, Howard. I believe he's captured that question.
Thank you, John.
Yes,
yes, John,
final question.
Would I ask?
Yes, please. Go ahead.
Yes, my name is Molo Agutu. Thank you for the presentation today. I have a quick one. So to Dr. Osoro, the first question is on testing. Does AAR cover the cost of testing? Because you've seen MPs and senators were able to, all of them were able to get it through their insurer. So I was just wondering, what is the role of AAR and other private insurers in facilitating the testing? And then to Dr. Korir, there's the issue of testing. I know our numbers is slightly below 19,000. So could we get a breakdown of the number of tests done per county? That will really give us a picture of how bad the situation is. Maybe moving forward, maybe from today's review. And then to Dr. Atwoli, in finishing up, there's the issue of the asymptomatic patients, because from the statistics, we see that majority of the people who test positive are asymptomatic. So really, what is your opinion on us keeping the asymptomatic patients occupying our hospital facilities, occupying our, our resources, HRH, the little resources we have? Instead, these people could be managed at home because they're like you and me. They're not people who are unwell as such. And then number 2, maybe in moving forward, now that it's clear we are not doing a lot of testing, what will be the plan now in opening up the country? Because it appears now there's really no plan and this could go on and on. What would, in your view, be a clear way of reopening the country? Thank you.
Thank you, Molo. Since we are completely out of time, I just have one more for Professor Atwoli before I allow them to respond to those questions and make their final closing remarks. So there's one that I picked from the chat. There's somebody who is asking, they didn't provide their name, for you to, asking for your take on the aspect of this de-escalation. We are currently seeing that in both Nairobi and Mombasa, that there's some kind of a sense of going back to normalcy. So what's your take basically on this? And with opening of eateries and the like, what's your take on this? So what I will do, I will ask Atwoli in reverse order. Atwoli, then you can go to Dr. Jared, and then finally Mercy. So you can respond to any of the questions that have been directed to you and give or make your final remarks. Thank you.
Thank you very much. Somebody has asked about dealing with this shortage using task shifting. I know that there have been a lot of international conversations around task shifting, especially in countries which are called resource limited. It is a very uncomfortable conversation for me, especially when you start designating a country as resource limited and then you develop solutions based on the fact that it is a poor country. I call this poor medicine for poor people. I have not heard, for the life of me, of a defense policy in resource limited settings. Do we buy counterfeit guns? Do we, I don't know. So health is just as important as security and so on. So when we talk about task shifting, we must think about it in that context. If we do everything right, then we will have the right skills mix for the right people for the right problem. And there is a roadmap to doing that. If you have that roadmap and you're doing that, then you don't need to have a conversation on task shifting. More importantly, if a community health worker is going around the community educating members of their community on health promotion, prevention of illness, and so on, that is not task shifting. That is the role of a community health worker. If a nurse in a hospital is monitoring a patient's vitals and identifying those whose blood pressure has gone up and initiating care for them, that is not task shifting. That is the job of a nurse, and so on and so forth. So really getting people the right skill mix in the right place at the right time is more important, in my view, than creating new cadres of health workers whom we call temporary cadres. But these are human beings. Human beings are not temporary. And then fixing them in the health system without a clear plan of progression and without a clear plan for the final ultimate solution to the problem that you're fixing. I think we need to maintain conversations on fixing the health system so that it addresses the problems appropriately without reverting to thinking that we are poor and we will remain poor forever. In any case, we are classified now as a middle-income country, and we should be driving solutions that are fit for a country that calls itself middle income. On the question of asymptomatic patients, I think in the beginning, when the numbers have been low based on our testing regime, it made sense to test the system by having everybody who is testing positive be admitted, be observed, so that we collect data, see the cause of the illness, see if it is true that our people, most of them will remain asymptomatic for the course of treatment and so on. As the numbers mount, this is not going to be sustainable. If we have, thousands of patients who have tested positive but have no symptoms, more than 85% of them will have mild or no symptoms at all. It makes sense to make arrangements for people to stay at home, self-quarantine, self-isolate in their house, and observe. If they develop any symptoms, then they can be taken to hospital. It will not be sustainable to say that everybody who tests positive will be put in a health facility manned with the human resources that are scarce, using services that they don't really need in a hospital setting. So we must consider the possibility of managing people in their homes when there's widespread community transmission. On the plan for reopening the country, I would say first and foremost that if I spoke to a plan for reopening the country, I would not be speaking as a health professional, because that's not the province of a health professional to tell the government when they should reopen and when they shouldn't. The task of health professionals is to provide information that then allows those that close the country in the first place, the political authorities, to make a decision that is informed. And the information that they need is, firstly, when you close, you do tests. When you have tested, then you go back to them and say that this 80% of the people in this area are infected. So it doesn't make sense to force them to stay in their houses if almost all of them are infected. So you can reopen, but then not allow anybody to come in or anybody to leave, and so on. So that is the kind of decision making that would be useful from a professional perspective. Right now, on the reopening of restaurants and so on, I would confess that I do not know the rationale behind the decision to allow restaurants to operate now. The rationale is not health. I believe it might be economic or financial, but it has very little to do with improvements in the health status of the country that then allow us to start a phased reopening. Only data will inform us on when it is safe to do so. And that goes to the same question about the escalation. We haven't even really properly escalated, in my view. If we tested and found that all the cases are in the areas that we have restricted movement and that the rest of the country does not have any infection, then we would keep these areas locked up more severely and let the rest of the country operate as normal. But if we find that the infection is uniformly spread all over, but the prevalence at the moment is low, then it makes sense to continue with a policy of widespread movement restriction, keep people at home, and so on and so forth. Ultimately, it is data-driven, and if you do not have the data, it is difficult to make a decision on what to do with the people. It remains a political decision. The politicians will estimate the risk of taking either side of the decisions, and they will make the decision and take responsibility for it. My final words is COVID-19 is indeed a severe illness. When you get it, chances of getting severe illness are high. And this is why we need to take these universal precautions. However, the majority of people who will get COVID-19 will get mild or no symptoms at all, and those who will get severe symptoms or moderate symptoms will recover. Majority of them will recover. The reason why we are doing the measures we are taking is to reduce the number of people needing health services at any given time. So if we can spread it over 1.5 years, that is a good goal. So we take it seriously, but then we do not take irrational decisions that are not informed by data and by science. Thank you very much. I hope I have answered as many as possible.
Yeah, thank you, Prof. Let's move on to Dr. Osoro, please.
Hi. I think the question I was sent to us or asked to look at is the issue of testing, if I'm not wrong.
Yeah.
Now,
testing and your final remarks, yeah.
Okay. I think when I looked at what he said that MPs were all tested. I just have two ways of looking at it. If we look at the people who are insured with medical insurance of some sort, if we decided to test all of them, it would cost us not less than 18 billion shillings just to do the test alone. Looking at insurance premiums for medical insurance is around the rate of 40 billion. So I think that means that we take half the amount of premium and do the testing. Basically, what I'm saying is this: in medical practice and insurance, you do the test depending on the necessity. And for us, we are more into managing the healthcare at the point of need. So if you get unwell, then we come in. And I think then the testing will be directed by the health professionals on who is to be tested. Now, widespread testing, as Professor said, this should be carried out by the national government of the area. And I think that they may be able to have, they might have the capacity and the funds perhaps to do significant testing. For insurance companies, for it to work, I think it has to be left to the point of need, where then the health professional will make that decision on what point to test, on which tests to run when. So I think we can leave it at that. For me, again, I'm just going to reiterate what we had put earlier, and has been said in final words. And we need to look at healthcare in a holistic and long-term view. As Professor has said, we need to now prepare for anything. We need to have a system that can take care of a pandemic. I shudder to think imagine if this pandemic was airborne, what would be happening? We need to have such scenarios tested, and we are ready for that. We need to look at the data and knowledge. Let us collect data well, let us manage it well, let us disseminate it well, including knowledge. Let us also cooperate, work together. I'm sure it is usually stronger when we work together. And then let us adjust to a way of life with COVID. We need to get moving. We need to move. We cannot stay stagnant. We need to move. And I also assure you of the support from the insurance industry. We'll always be here for you. We're already working on ways to go past this to ensure that you and I will get out of this stronger. Thank you.
Osoro, And finally, Dr. Mercy.
Okay, so mine was just one question, so I'll make it very brief. And the question was the testing that we've done. So far, it's been less than 20,000. Can we have a breakdown per county so that we know how we are doing? I think the sources of all this testing is from the private sector, and the private laboratories that so far are doing this is Lancet, Nairobi Hospital, and the Aga Khan University Hospital in Nairobi. And then from the public sector, we have the KEMRI chain of laboratories from the Nairobi headquarters, Kilifi, Kisumu, Kericho recently, and Busia. And then now the National Influenza Center, and most recently Kenyatta National Hospital. That should come to about 10 laboratories. So the government has not broken it down as to testing per county, but they just lump all the testing, and then what they break down is the number of confirmed cases. So yes, I agree that our testing can be better, because the more you test, the more numbers you're able to capture, and the more information you're able to get, on the extent of the transmission, local transmission now that we are seeing, and would be able to advise on the containment measures to take, whether you're going to escalate or de-escalate. As it is now, not every county can test, but you expect that the counties in the coastal region will do their testing in KEMRI, Kilifi. The counties in the South Rift will do their testing in Kericho. Those in Kisumu or the Nyanza region will do in Kisumu. Those in Western will do in Busia, and so on and so forth. So there is this coordinated mechanism that should make it easy for testing to be better. I know the other plan was to engage the gene expert machines, about 187 or 193 or so in the country, that would do about 20 tests per day, and that would increase the amount or the number of people that we are able to test, so that we are able to capture as many numbers as possible. So our testing is still not adequate. If you compare us with Uganda, which is doing much better, I think we can do better as a country in terms of our testing capacity, in terms of our logistics around the testing. So my final remarks really is that looking at where we are now, I think it's about time as a country, or even as individuals, we start having a conversation on how to move forward. And I think all my other panelists have said the same on how to move forward and how to live with the coronavirus, because clearly it is here to stay. And if you've seen other countries, I think my best example has been New Zealand, where they are slowly opening up. And they are telling people that, we are not yet out of the woods, so these are the measures of how to live the new normal. So I think it's something that we should be able to look into, obviously not exposing as many people as possible, and particularly our most vulnerable population. So if we start thinking around this and how to cushion our most vulnerable populations, and how to have the health system respond at the earliest possible to those who are in need, then I think we are able to find a way of living with the pandemic, containing it as much as possible, up to a point where now we have totally done away with it. So here we have a mix of having proper health interventions, and then also having social protection and economic reintegrating back into economy. So I think it's a delicate mix that is a conversation we should have, and look at it on the long term, even like 5-year projections, so that we are able to see it end to end, and we are able to actually factor in everything and everyone, so that we know how to live this new normal, or have a way of moving on from this current situation that we are in. Thank you so much for this opportunity.
Okay, thanks a lot, Dr. Mercy, Professor Lukoye, and Dr. Osoro. So wherever you are at, whether in the office, whether you're driving or at home, please help me to appreciate them with a clap. So thanks a lot for helping us and partnering with IEA to elevate and promote this discussion and educate the public as well, and also provide some insights that that have been picked by or that would be picked by policymakers. And for us as IEA, we are very grateful. I know Winnie and us, has noted some of the issues that will pick up in terms of further research or further work. So we are very grateful for this. And just to reiterate, actually all the slides will be posted on our website in a short while. And so you can, at your own free time, go to our website and you'll be able to access the materials that have been shared. And the other thing to note is that IEA is a membership organization, and so you're also welcome to register to be a member. And again, you can go to our website. We're also very grateful to Winnie for putting this together, and we'd like to note that IEA will continue to hold more series around COVID-19 in relation to its different programs and themes, as well as other different public forums. So please look out for this in our social media pages and in our website. So thanks a lot and have a good afternoon. Bye.
I'm done, guys.
The relief you're feeling right now, eh?